you're studying for 420? Do you understand the content that they're saying? This is the, again, the nitty gritty of it all. Basic care and comfort, 9%. That is literally your toileting, your repositioning, feeding, dressing, those very basic ADLs. Psychosocial integrity, a lot of that is going to be built around communication, therapeutic communication. Do you have a question on that? No, you're just working on your hair, okay. Health promotion and maintenance, this is something that you're definitely gonna pull out every time you do, or you're sitting there working on your project, your presentation. What kind of education can we provide to this older adult so that they have early interventions or early screenings, blood pressure clinics, lipid clinics, they do, what's the one next to us where they do, I'm trying, my brain is going to the Iowa State Fair and the nursing students, and we share one, it's like it's something with the eyes. No, might be stroke, I don't know, it doesn't matter. But you know, pulling that piece in, how could we prevent the problems from happening? Get your COVID shots, get your shingles shot, get your pneumonia shot, that type of stuff. Safety infection control is pretty huge. I mean, really, it is very foundational stuff. This is your restraints. Can we tie people up? Well, what kind of parameters are out there that we have to make sure that we follow, that we understand? Do we understand what, what contact, what isolation needs to be for a certain problem? Like if I said measles, you would say, I don't know. Airborne. I didn't go through all of it, that's fine. Then the cool thing is you get down here and it breaks it up even more. So the big heading, the safe and effective care environment, and then you have the breakdown of the management of care. This is all great stuff, but I'm gonna skip past it because it breaks it down here even better. So the very first thing up there, advanced directive self-determination and life planning. Assess client or staff member knowledge of advanced directives. So I'm giving my presentation. I'm gonna say that test map says you need to know what an advanced directive is, how you formulate one, when does it come into play. Do you guys remember? Can you tell me about advanced directives? When does it come into play?
When someone can't make their own decisions.
Once they are incapable, they have been deemed cognitively impaired enough that they can't make those good decisions. Because up until that point in time, we're gonna honor that patient's wishes. Then we hope that the patient, the client, has talked with the DPOA, and the DPOA then is going to carry out the wishes of the client. But it's not gonna go into effect until the patient is unable to make decisions for themselves. So they're gonna name somebody. Durable power of attorney. You may hear the term proxy, P-R-O-X-Y. Proxy is that DPOA person, whoever was picked. So then what's the difference between an advanced directive and a living will?
Isn't there not a proxy in the living will?
There is not a proxy. Because both documents are probably going to have what the person wants and doesn't want done. It can be very specific. It can be, do not, I'm a DNR. It could be, okay, well, you can use medicine to try and restart my heart, but I don't want to be on a ventilator, or I want everything done. advanced directives. Let's see what else, let's start on page 33. I literally had this book open when I was writing your test. Ooh, it says NCLEX connections, and then it breaks it down, it says management of care. There was a highlighter. The PSDA requires that all clients admitted to a healthcare facility be asked if they have an advanced directive. Would somebody Google PSDA for me?
What page is that?
On 37. I don't know what that abbreviation is for.
Patient self-determination.
Ah! That could be a question.
Which page?
37. Patient Self-Determination Act. I could see a question being, this is a scenario, which piece does this fall under? And it would be, oh, the advanced directive is part of the Patient Self-Determination Act. So we have to ask you, if you have one, we have to ask you to please bring a copy to us. We have to ask you, do you want help formulating an advanced directive? It says they must be given written information that outlines their rights related to healthcare decisions and how to make an advanced directive. And then it goes on and it talks about the different components. The living will, most state laws include provision as long as healthcare providers follow the advanced directive, they're protected from liability. And then it goes on down to the durable power of attorney. We sure hope they're familiar with the patient's wishes. Then it goes on to say living wills can be difficult to interpret, especially in the face of unexpected circumstances. So they like for the person to have the living will and the advanced. Are we all waking up? Are we sleepy?
I needed it.
Okay. Do you need, you probably need more chocolate. You come up and get some more chocolate. So one's not better than the other. We like for them to have both. Unless a do not resuscitate order is written, the nurse should initiate CPR. So what does that mean? What is the responsibility of that nurse? Besides to do CPR, what else? Think bigger.
To let me know if they have the DNR.
Know if they have the DNR. To, hello, Dr. Smith. I am taking care of, Susie and Susie's family. I'm not giving a good S bar, don't judge me. Family says that she's a DNR and she doesn't have a living will, she doesn't have an advanced directive, but she told family she does not want to be resuscitated. When it's her time to go, it's her time to go. That nurse has to get an order. There has to be an order. It's just about protecting the nurse at this point.
Has to have an order.
From the physician for DNR.
Okay, so they would just do the CPR and be like, hey doc.
Yep.
This is the situation.
So then what if the patient comes back alive and they're mad because you gave them CPR?
Maybe they'll get their advanced directive.
And say, well, the other day when we were in the CCU, the paramedics found like a lady in the ditch in her car and they did CPR on her, brought her back to life, and then they found out she had a DNR. Her family was not happy. They were like, we found her like in a ditch, like.
So they would be protected.
Yeah.
Under like the liability, they would be protected because they didn't know. It is usually a pretty big thing in report. They are a DNR. Some facilities will actually ban a person. Other facilities will have like some type of signal, something visual, either on the chart or in the room or on the door if they're a DNR. So we gotta have that order. And of course, we're trusting that the provider is the one who's responsible for carrying on that conversation, that needs to happen. In Iowa, they call it the I-post. You guys, somebody said, okay. So what's the nurse's role? We're gonna give them that written information. Make sure it's current and reflective of current decisions. Informing all members. That's it right there. Integrates advanced directives into the client's plan of care. Here's just a conversation starter. The resident that died in the nursing home and was sent to Ankeny, declared dead by 2 nurses, declared dead by the funeral director. You take her to the mortuary, the worker goes to unzip it, and what happens? She's gasping for air. What would you be, put my George, right?
Oh, yeah.
Just the way it played out, they called 911, they did some resuscitation, they took her to Mercy One. Mercy One sent her back to the facility based on the wishes of the family. And I believe she died the next day then with her family around her. Can you imagine if she had been a code? Think about if she had been a code. Huh? The facility got fined $10,000 by the Iowa Department of Inspections and Appeals. And I can only think what, how much higher that would have been, if she had been a code. You're like, oh, that's just so weird. I mean, it made the national news. That's so weird. I don't think, have I seen you since I told you I got a phone call? My other job? No, I haven't seen you guys, right? We need to notify, the on-call provider of a resident's passing. Okay? This provider doesn't pick up, so I leave a message, this is Shirley, first nurse, I need you to call this nurse at whatever facility. They need to get a release, in order to release the body. And hang up. Probably 20 minutes went by. And the nurse called back. And she said, the doctor hasn't called back, but we don't need him anymore because the patient is alive. So weird, right? Like you think this would just never happen. Dead is dead. And we take 2 nurses and we listen to that chest, we listen for that heartbeat, we look for breathing, even if it's really shallow.
So nothing happened to the nurses or the funeral person?
Nothing. For which one? The one in Ankeny, nothing happened to the funeral person, but the facility got fined big. I don't know any other outcomes of this other situation. I was off by the time the patient actually did die. I didn't take that phone call. Crazy.
You said it takes 2 nurses to do
2
that?
nurses in Iowa.
Because usually at places, there's only 1 nurse, like at night shift, so how does
Yes.
that work?
That's a great question. I think from what I was reading, cause you know how you like to do weird things, and one of the things I do is read department inspections and appeals, cause it was part of my life for so long. I think that the other nurse was not a nurse. I think it's an LPN and then like a CMA. And they didn't say anything wrong about that in the. Okay. Nurses are accountable, oh, that's a whole different thing, okay, I'm done with that one, okay. Provide information about it if they ask for it. Advocacy. There are several questions about advocacy on your test. Anybody share an example when they felt like they advocated for their patient? even if it might have been like with your nurse. Got one
Patients refuse showers because they don't take them during the day, they take them at night. All that stuff.
As advocates, nurses must ensure that the clients are informed of their rights and have adequate information. Nurses must be careful to assist and not insert their own personal opinion. What page are you on? I'm on 36. I went backwards. Advanced directives was on this page, I'm over here. Nurses can mediate on the client's behalf when the actions of others are not in the best interest. Situations in which the nurse might need to advocate end-of-life decisions, access to healthcare, protection of client privacy, informed consent, and substandard practice. I had a situation happen that I am so mad at myself to this day, because I tried to advocate, but I was intimidated by the physician and I didn't push it. And it was with a kid, maybe I told you this in peds, it was a kid that had a horrible infection on the top of his hand. And I had been given sedation meds to do like a conscious sedation, had the monitor set up, had all the drugs drawn up, ready to go. We're in the treatment room and the doctor's asking the kid how it happened and they're talking. And then he starts the procedure and like at least 2, if not 3 different times, like, can I give him something now? Big old alligator tears are rolling down this kid's face, a teen. Oh, he's fine, he's doing fine, he's fine, whatever. At the end, he never let me give anything. At the end of the event, when the patient was back in the room, the surgeon said, when I asked him how this injury occurred, he lied to me. And that is why the surgeon did not let me give those meds. I thought I was advocating, but what should I have done? I should have stopped it. I'm like, no, we need to stop. I did, do a write-up, like I did report it, but gosh, to this day, I wasn't braver. So we're still responsible because we are expected to use our common sense and the knowledge that you gained in nursing school and your experience. Talks about essential components of advocacy: risk-taking, vision, self-confidence. Sherry was lacking. Articulate communication. The clearer you can be. If you're not sure you understand what the nurse asked you to go do, what should you do?
Ask for your opinion.
Yes. Or repeat, so this is what, and I have done this one, so this is what I understand you want me to do. And then I would say it. Making sure, because sometimes you get a little nervous. And then it talks about the caring, autonomy, respect, and empowerment there. Act in the role of client advocate. Utilize advocacy resources appropriately. I think we do a lot of this as nurses. You know what? I really think that that patient could benefit from this. Where somebody else, it may never have crossed their minds that is a huge piece. Okay. Assignment and delegation, I'm not going there. It doesn't apply to geriatrics really specifically at all. This is a huge piece for next semester in your leadership class. Case management. Anybody know what case management does? In words that we use.
I like social work.
It's a lot of social work. Case management is plays a huge role in the continuum of care. For a lot of these folks, again, I'm gonna keep it the geriatric basis, that need maybe some at-home services because of whatever happened. Maybe they came in for a stroke or a heart attack or AFib, who knows what. Do they have what they need to be able to return home and continue to heal? They also are the ones that get to chase down the doctors, the providers, when they don't have the diagnoses to keep the patient in the hospital, or they wanna do a procedure without the right documentation to be able to have Medicare, Medicaid, insurance companies approve it, I could never be a case manager. But it says practice and advocate for cost-effective care. If they feel that that person would be just fine at home, that's where they want them. And then that continuum of care piece, do they have what they need? And I'm gonna tell you, they send people home a lot and they do not have what they need. It's a true story. Provide a client with information on discharge procedures. That's the nurse, that's the floor nurse. I don't, you can say it's case management, but initiate, evaluate, and update the client plan of care. Even with the clinical judgment model, we're still using that phrase. Moving on to client's rights. Recognize the client's right to refuse treatments, procedures, showers. When I was a full-time in the nursing home, we had a tech that would come in. She'd start at 4. How'd you like to be woken up at 4 o'clock for a shower? I wasn't her boss, but I probably would have intervened there. Discuss treatment options, decisions with the client. Provide education to clients and staff about clients' rights and responsibilities. You guys remember in 250 when I was trying to expose you guys to this, you Googled into like Mercy or Methodist or whatever, and you pulled out those clients' rights and responsibilities? What page am I going to now? Is it? Aha! 35. Clients' rights are the legal guarantees that clients have with regard to their health care. Retain their rights to be treated, to not be treated. The AHA identifies clients' rights in healthcare settings in the patient care partnership. And it even talks about residents in nursing facilities that participate in Medicare programs similarly retain resident rights under statutes. Do you think that sometimes maybe in a nursing home scenario that our residents lose some of their personal rights? Maybe? Maybe depending on the nursing home, depending on the situation with the, remind me, is anybody that worked in long-term care? Have you seen wherever you felt like maybe clients' rights were stepped on?
I mean, yeah, especially like those with dementia and stuff. I also just feel like, I don't know, I see like a lot of neglect too. And it's so sad.
I wanna live a long, healthy life, but I don't wanna be in a nursing home, so just take them before that. Take them before that. So again, it kind of comes back to, do you know that the client's rights include informed consent, refusal of treatment, the right to be able to have an advanced directive confidentiality, and information security?
I have, there's like a lady, she does activities and stuff, and she'll like make some of the residents, like for like hymns and worship, she'll like make them go, and she'll be like, they don't need to take a nap, they can just go. And I will always say, like, if they don't wanna go, I'm not gonna force them, especially if they're not religious. Why would I make them go? And she'll literally go in there and like wake them up, oh, you can sleep later, let's go. And I've said something, but no one ever does anything.
Again, that whole advocating piece, when you can, but, you know, like, our voices aren't always heard, unfortunately. Okay. We're supposed to make sure that they understand their rights and also protect their rights. Have an active role in this decision-making process. Again, accept, refuse, or request modification to the plan. Receive care that is delivered by competent individuals who treat the patient with respect. And I'm thinking about how we have to extend this out in our geriatric community. We have Fred, who's in the hospital with pneumonia and a DVT, and he's got dementia. And no living will or attractive, but he's married to Mary. Mary is his next of kin, they would go to her before they would go to his kids, as long as she's competent, can make decisions. So we even have to extend that concept of patients' rights to that next person. Heavy thing to talk about. Okay. I want you to be able to recognize that Patient Self-Determination Act covers that refusal of treatment. So what do? I don't want to take that, I don't want to do it. How as nurses should we respond to that? Like, oh, these old people. What's our role? What's our role? Do we threaten it? You know what, your insurance company is not gonna pay for this visit if you leave right now. That may or may not be true, I have no idea, but that's certainly not the way. How do we handle it? Somebody doesn't want a treatment, somebody wants to leave. What do we do? What is our role?
The leaving against medical advice.
So what does that entail?
They have to like sign a paper saying that they understand that they're leaving, even though it's not what's recommended.
Can we get that consent, or does the doctor?
The nurse might be the only ones there, but you're gonna get a second nurse that's going to witness. I've had people that have refused to sign the paper because we want that signature. It even says in here, the client is asked to sign a document indicating that they understand the risk involved with refusing the treatment and that they have chosen to refuse it. So part of our documentation of nurses is I explained, and it's all going to be clearly documented, that you explained this to the client, and that second nurse is going to be your witness that yes, she told him, the chances of him becoming much more sick and possibly dying because he needs these antibiotics, that was clearly explained. All, of course, is just objective documentation. Leaving the facilities the same way. Unless they sneak off, which does happen occasionally. And of course, that the provider is notified. And says this is what they need to know, possible complications without the treatment, possibility of permanent physical or mental impairment, possibility of other complications that could lead to death. We ask them to sign the form. If the client refuses to sign this form, we do that as well. This again, I think the collaboration with the interdisciplinary team, I don't think that is, you just know with, especially again, the older adults, that there is absolutely collaboration. It may be with the pharmacist, the occupational therapist, the physical therapist, respiratory therapist. Just go on and on and on. And it might be the nurse who gets that rolling. Hey, we need occupational therapy in here. This patient is really starting to get some it's starting to kind of act like you can get a contracture. Let's get OT in here, maybe get physical therapy in here and see what we can do to prevent this from happening. I'm gonna scroll on down to confidentiality and information security. Assess staff member and client understanding of confidentiality requirements, maintain the client confidentiality and privacy, and intervene appropriately when confidentiality has been breached. Have you guys ever seen a breach of confidentiality, you go, ooh.
I just found out this morning that one of, the other, like, universal workers were, or two of them were making TikToks, and one of the residents was in it.
Bad. It's absolutely not okay. Anybody else? I almost stepped out of my office yesterday, but there's just like a point in time, like, there were students discussing a clinical event. I'm like, I'm good with us in post-conference, I'm good with us in class with a closed door. I almost got up, but there was no names. But so many times, it's kind of like the situation. In this day and age, something that could be on the news, and people could put two and two together. So it's just like, you just can't be careful enough about it. Let's see where we go on this page. We're doing more flipping and more flopping. Nurses who disclose client information to an unauthorized person can be liable for invasion of privacy, defamation, or slander. And then we have HIPAA, which those laws are enacted to protect the confidentiality of healthcare information and to give the client the right to control the release of information. And then it goes on into some more specifics. Geriatrics. Daughter calls up. You don't know her. You've never met her. Hey, I'm just calling about my dad, John Smith. I think he's in room 318. I just wanna know how he's doing. Can you tell me? Well, you know that he's a really nice guy and he probably wants his family to know that he's doing well. What is my response to this person? What is the right response to this person?
Having them hold so you can check the release of information.
When we were in the ICU, they asked us if we wanted a code. Have you guys seen that on any of the charts? Like a family code? I would think it'd probably be up there like in the yellow sticky on Epic. No? So they will, a lot of different places do things differently, but when the family has this code, that means they were given the code, being given permission to call, and for that kind of information. There's even situations where it's even more, sensitive than that. Like, you don't even want to acknowledge that they're in the hospital. So that's the direction I would encourage you as you're thinking about your nursing practice, that, definitely, I'm gonna put you on hold for just a moment, okay? And then figure out what your game plan is, because gosh, one of the things that you can recommend is that they call the hospital operator. I'm not sure if that person is I'm not sure if that person's here. I'm gonna send you to the operator. What does the operator have that we may not know, depending on how busy our shift is, how sick our patients are. The operators are really tuned into the no pubs. So that's a great direction to go. You send them to the operator and the operator gets to deal with it. How could you go wrong with refusing to talk, really? And then it comes front and center and there's the wife and she goes, oh, absolutely, this is my daughter and you guys were gonna tell her how dad is doing. Well, we were wanting to protect his information. How much trouble would that really get us in if we followed the guidelines that we're expected to? It's as simple as pulling curtains, shutting doors, keeping parts of their body covered that we don't need to have uncovered. They have rights to obtain a copy of their medical records. and to be able to submit requests to amend erroneous or incomplete information. And we know that the insurance providers get to have access to that information, that's kind of where HIPAA began with. And it goes on and talks about the privacy rule. Components of the privacy rule. Only healthcare teams directly responsible for client care are allowed to access the client's records. If you're not taking care of them, stay out. The next one to me is kind of interesting. Have you ever heard a family or a patient say, I want to read my chart? Do you know what your response is supposed to be? We have a process for that, and I will need to get a release of medical information signed and send it where? To the medical records. Have you guys seen, because you're the front lines now, have you seen where they're providing iPads to the patient, to the family? And it's kind of like my chart, only it's like everything, like the progress note that infectious disease wrote is gonna show up there. Have you guys seen that? I think it's like the coolest thing. I mean, talk about being kept in the loop. How could that be bad though? It could be good, it could be bad. How could it be bad? I mean, I was constantly like this.
If it gets left out and the patient's information still on it?
Could be. Mine, I mean, ours was in our room. Do you know what I did? I took snapshots. Cause I sent it to people. I'm like, I need to make sure I understand what this says. My sister works for a doctor. Have you guys studied about PEs yet? Pulmonary embolisms? What do you think about my husband when you get there with Sarah? The classic NCLEX sign is petechiae on the neck. I almost didn't really believe the doctor when he said that he thought he threw a PE because the rash wasn't there yet. And then the rash was there, like, didn't know what he was talking about. Guess what his PE came from? I told you guys this, I'm repeating myself, I'm gonna keep going. Continuity of care, huge, huge piece. Huge piece. All that stuff under the privacy rule is stuff that you need to be aware of. Okay, so continuity of care. Somebody seen it? Guide me to a. Might be in a different section.
26.
26, thank you. Poor communication can lead to adverse outcomes, including sentinel events. Have you guys been in a class that's talked about sentinel events? They are a real and present danger for us. I have been in two. I've been directly involved in two, indirectly involved in a third one. I had you guys when I was summoned. What did I? And I had to go, I got deposed. Ugh. They happen. So what do you suppose your best protection for a sentinel event is?
Your documentation.
Your documentation. Absolutely. There was death in 2 of the 3 that I was involved in. And that's what the whole S-bar thing is about. Now there's I-bar. Have you noticed as you've gone to different units that the S-bars might look different depending on what area you're in? Yeah, we got PACE, I passed the baton, the 5 Ps, all of it for safety. All of it for safety.
There's more on 25 too, sorry.
Oh, perfect. We'll get there. Okay, perfect. Talk about email communication. Don't use text abbreviations. We do text messaging to some providers, not all providers do it. But it's not like it doesn't go to their phone, I think it still goes to a pager, and then it runs across the bottom. And so here, we're trying to be like super abbreviated, because we just know we only have so many characters, but you can see where that can lead to poor communication. Usually they'll just call me, what's going on? Handoff or change of shift report, again, just so pertinent. Any particulars for that individual, new medications, labs, any concerns of the family, of the patient. You wanna be in the know. When my husband was transferred from ICU to the floor, the drug that he needed, fell off. Just done. You know what the nurse came in and told me? The doctor's putting him on a new antibiotic. Do you not think that my antennas went up? What? The doctor rounds, and I said, so what's this new antibiotic that you're starting him on? Oh, I'm not starting him on new medicine, it's amphotericin. It was the antifungal. It fell off. The nurses did not catch that. The provider did. Darn it. Because nurses catch a lot of stuff. We really do. Should be in a private area. You gotta be mindful of like who's around you. Who might hear stuff that they don't need to hear. And then you said there's some on the back. Continuity of care is described as a client's move from one, it might be to the ER to surgery, ER to the floor, ER home. It might be from the floor to the unit to the floor to a long-term care facility. And we just have to make sure that person receiving your patient understands all the ins and outs. It's the most important stuff there. Nurses are responsible for this good communication. When I was taking questions on API, this last bullet point was a formal written plan of care is the answer for continuity of care between facilities or units. Highlight that. And it goes on to talk about more and more and more. Who's responsible for, okay, I wanna transfer a patient, I work at Mary Greeley and I wanna transfer a patient to Mercy. Who's responsible for that phone call? I will help you out, it's not you. Those kind of transfers need to be provider to provider. It goes on and on, making sure those orders are there. This is real stuff, guys. I have, okay, again, triage nurse. The nursing home nurse calls me. Of course, it's 6 o'clock on a Friday night. They just got a transfer from the hospital and had no orders. Some RN was sleeping. I think on both ends. Because the nurse certainly facilities know that someone's coming. So that nurse could have also have reached out before they left and said, hey, I need a report. I need to know what prescriptions this patient is supposed to be on, what his diet level is supposed to be. You wanna have fun? Page a provider who does not know the patient for nursing home orders. It happens, really, really does happen. Documentation to facilitate continuity of care include those graphics, the flow sheets, the nurse's notes. summaries, the nursing care plans, and then we get to flip the page. Good stuff. Do you see, Esther, with your work here and there and everywhere, especially the ER, do you see issues with continuity of care?
I think they're pretty good about that actually, but I do see where they like get frustrated with each other, cause I've sat in the ICU and somebody will call from the ER to give report, and the nurse is sitting right there, but the nurse on the phone will be like, she's, you know, in the room with the patient right now, but she'll give you a call back, and I'm like, she's sitting right there. You know, to give report and stuff, and I'm like, you guys, they're right there, just give the phone over.
Establishing priorities, that's not anything testable there. You'll work a lot on this next semester as well. With prioritization. You can go on down there, it talks about ethical practice. Who wants to help me out? Ethical practice. Going once, going twice. It's in the chapter 3. I want to make sure that you ladies, you understand those definitions under ethical principles. I might literally have picked a question for each one of them, or really close. Autonomy, when is the nurse advocating for patients' autonomy, beneficence, fidelity, justice, non-malfeasance, and veracity. So literally, like in the question, it'll give you a little example, and it's like, what ethical principle is the nurse displaying here? You can imagine that nurses are put in the middle of this situation quite frequently. Families against each other, siblings against each other. A lot, the biggest thing there was, for me, was the definitions. And I know you all know that there's a code of ethics for the nurses. Doing good on tenure. Informed consent. Ooh. Identify the appropriate person to provide informed consent for the client. Is it you?
No.
No. It might be the radiologist, it may be the surgeon, the pain clinician that's doing the walking epidural, whatever. What is our role?
It's the witness.
We're the witness. If it's paper and pen, it might be us writing what the procedure is and handing it to the surgeon, handing it to that provider that's going to obtain that. So yeah, we absolutely can have it readily available, and we serve as witnesses. If something happened, let's say they took, they operated on the right side instead of the left side, and now the surgeon gets sued, you absolutely, if you're the witness on that, you're gonna be, no, I heard the physician say right side, it says right here on the consent that it was the right side, that is what I heard and that is what I witnessed. So nurses can absolutely be called in such, situations. This next one is hard. This can be really hard for a lot of places. Provide written materials in client's spoken language. Most of your organizations are gonna have some plan in place. it may be phone, phone for help, phone a translator, but most organizations take care of that already. Let me see what important things I want to point out. I think I already did, but make sure I'm not missing anything. Witness the client's signature and to ensure that the information or the informed consent has been appropriately obtained. If they're demented, you'll probably have a problem. They shouldn't be signing. If they have varying degrees of confusion, probably shouldn't be the one signing that. Who's gonna sign it?
The power of attorney.
Power of attorney or the next of kin?
If they don't have those,
What's that?
if they don't have either.
That's gonna be well documented. And they're probably gonna they're probably just gonna try to get a phone, there's phone orders, there's phone consents. What do nurses have to do if they get a phone consent from a family member? What's that?
Follow up with the written, like when they can come in.
Doesn't someone else have to hear it too?
So it would just go into the chart as documentation that permission was received and, consent was agreed to for whatever, and that Hannah RN served as the second witness. You'll see nurses hand the phone to each other, you'll hear just like they can pick up and pick the line, both of them being on the,
So doctors don't have to do that when it's over the phone, cause I thought like the informed consent, the doctors have to get the consent. Like the.
this would be for non-procedure stuff.
I heard it when I was in the ICU at Lutheran, they did it for like a medication.
Yeah.
Or something.
My daughter, who turns 18 this, whatever the 10th is, Friday, went to the doctor and they called, like I was in class and I had to watch for my phone because they called to verify that I gave my consent and then they had a second nurse. So informed consent for a procedure, the doctor has to do the describing. And then the nurse would say, do you have any questions about what the doctor said to you and what's gonna happen? There'd have to be that piece, would have to be there. Because, right, nurses don't give it. If it's simply for treatment, maybe to, I don't know, start an IV, do a catheter. But those are considered, like the IV, the catheter are considered just normal day in, day out things. So consent is of course not required. We want the person to be okay with it. But you might have a demented old person that's not gonna be okay. And we have to do it anyway. And then we put them one-to-one so they don't rip their catheter out. Crazy stuff. So seeking that interpreter is a huge piece there too. For an invasive procedure or surgery, the client is required to provide the written consent. State laws regulate who is able to give that informed consent. The nurse must verify that the consent is informed and witness the client signed the consent form. The person who signs the form must be capable of understanding all of the information. There's another piece that I want you to make sure that you know about informed consent. It's not just, I give permission for you to give me a new hip. What else does that physician have to provide that the nurse is witnessing?
Potential like complications.
These are the potential complications. These are the potential risks. A lot of them will even give statistics because they're nerdy that way. This is the kind of pain I think that you'll experience afterwards. This is the kind of pain medicine we're gonna give you. They have to go more than just, oh, you need a new hip. So sign up this piece of paper that says I give you a new hip. Risk, benefits, problems that could arise, all that good stuff.
Doesn't the patient also have to like write down or like verbally say what the procedure's gonna do. Or like, cause when I was in the, I don't know what the floor was at Lutheran where you see surgeries, or whatever, every single patient's room that I went into, they had to say, they had to verbally say or write down, like, the procedure I'm getting is a hip replacement.
Wow, I have not seen that, but I think.
Like
Do you guys know what I'm
describing
talking
it.
about?
yes.
Okay.
In the pre-op.
Yeah,
That's
it said
crazy.
in your own words, please
Yeah.
describe, and they just.
That's
write.
awesome,
They did it in the cath lab too.
that's
really?
awesome, yeah. That might be the hospital's policy, because I don't know how many dozens and dozens of C-sections that I've witnessed, but they never said that. The provider would say, and you want a tubal ligation, tell me what that means to you, and they would say, it means I can't have any more babies, and then it's permanent, but it can't be reversed. I have seen that, it's a little bit more peppered. Okay. Good stuff. And if they have questions, we have to go find, gotta let the provider know if they have questions. Look at the information technology. Nothing with that. Save that for later. Nothing here yet. I just wanna share one other piece, since we are running out of time. You're gonna find stuff in here probably for your topic. Again, I only wanted about the old person, I want nothing young. Talks about aging process. Provide care and education for the adult client ages 65 and older. When I was looking back at, I don't remember what chapter it is, I went to chapter 5. It says common aging changes. When you are working on your piece, make sure you look at that and pull that piece in there. What is considered to be the normal aging process? I think that's the name of the chapter even, if I remember right. So look at what do we expect, because if we know that that's the way it's gonna be, that's one thing. If it's abnormal, then that's another. Here's the other part I would want to share with you. Developmental stages and transition. So if I was going back to the whole Erickson thing, let me not skip anything. Identify expected stages of development. Assist client to cope with life transitions, retirement. Modify approaches to care in accordance with the client's developmental stage. Provide education about expected age-related changes and age-specific stuff. But to me, this is all about Erickson, so definitely for this test, go back and look at those final 2 stages of Erickson's. Do you remember what those are?
Integrity versus despair.
So that's the last one. What's the one that comes before that?
Stagnation versus
The G word.
yeah.
Think about that person who just retires. Are they gonna sit in the recliner and rot? Or are they gonna get up and become involved in all the other things that they can still participate in and still have that good quality of life? And then that last stage, is there any regrets? Are they proud of their work and their life accomplishments? Or are they like, I wasted my life type stuff? So review that when it comes to, in the readings for, the point. I think it's like, not very, a paragraph, not much. So you're gonna pick your, did you see how I did that? I just picked each one apart and shared. I don't expect you to be that, like 10 minutes. It could be a 10-minute presentation. You can literally pull this up. You don't have to have a PowerPoint, although that would be fine. That would be great. I have taken every single minute. Okay, questions? So you'll lead the way when we come back. You will be,
Me and Kimberly.
spend some time making sure that you include drugs that are not good for a geriatric, okay? There are certain pain medications that are like, You can even, if you wanna talk about like Beers criteria, have you guys seen that phrase Beers? Those are the meds that are not good for the older population. The test will open at 2. You'll have plenty of time.
Is it gonna be like all in one thing? What?
It's on Blackboard and calls.